I'm Mark Walterfang. I'm an adult psychiatrist and neuropsychiatrist and also a professor of psychiatry. I have a specific interest in disorders of the brain, but also for a long time have practiced as an active clinician, seeing patients with a range of disorders in outpatient and inpatient settings, common psychiatric disorders, but also a range of neuropsychiatric disorders such as brain injury and dementia. As an adult general psychiatrist, at both inpatient and outpatient levels, I see high prevalence disorders such as depression, anxiety. I have a strong interest in psychological therapy, treating patients with childhood trauma, which I've done for more than 20 years. As a consultation liaison psychiatrist, I will often see people in medical settings who may have depression, delirium, cognitive impairment, chronic pain. I have a strong interest in seeing patients with cognitive impairment and brain injury in particular, and for a long time have seen patients who have had work-related or motor vehicle accidents that result in complex multi-trauma or brain injuries. As a neuropsychiatrist, I will see patients who have disorders of the brain that have psychiatric concomitants or sequelae. Examples of this would be dementing disorder. I have a strong interest in young onset dementia, as well as a range of other neurodegenerative disorders that I have more than 20 years of expertise in addition, in particular, to acquired brain injury, having worked for more than 15 years at the acquired brain injury unit at the Epworth Hospital. So as an adult general psychiatrist, I will tend to see the more common high prevalence disorders, but I've developed significant expertise in managing psychiatric disorders that happen in the setting of major physical illness, but also in the setting of significant organic brain disease. I became interested in psychiatry as a medical student, did a number of rotations in psychiatry. I think what interested me the most was the almost infinite variety of effects of life and experience on people and how they process things and how they function, which I certainly didn't find in other areas of medicine. And as I trained and practiced, I think I experienced a great deal of joy in just effective treatment, whether that was psychological therapy, pharmacotherapy, psychosocial interventions, in just seeing people's lives turn around. I've really enjoyed doing that at both a private practice level, particularly psychological therapy, which I've had a long interest in for people with childhood trauma, but also adults who've experienced adult trauma. I've also had a great joy in undertaking research and teaching. I've been associated with the University of Melbourne for many years in an academic role. Early on doing a great deal of teaching, particularly of medical students, but also of psychiatric registrars. But I've very much enjoyed the research and advocacy role I've played in a range of psychiatric and neuropsychiatric disorders over my career. I've published almost 200 scientific manuscripts in the medical literature, and just enjoy the endeavour of discovering new aspects to illness, and in particular being involved in treatment trials, the development of new treatments. I've had a fantastic period at the Royal Melbourne Hospital, so closely located with other research institutes in the Parkville precinct, and developed wonderful and strong collaborations. And I think the great thing about my career is not only do I get to sit with patients, help them improve their lives, but also work with the scientists really right at the back end in preclinical aspects of disease to develop new treatment modalities, ultimately that will improve people's lives, perhaps in 10 or 20 years, but to be there right at the beginning is a particular joy. So being able to combine clinical work with people, seeing lives turn around, but also training our next generation of psychiatrists has been a particular joy for me for many, many years. For a long time, I've seen people with childhood trauma who've needed ongoing psychiatric care, often consisting of a combination of long-term psychotherapy as well as pharmacotherapy for disorders like major depressive disorder, post-traumatic stress disorder, generalized anxiety that often follow that. Over the last 15 years, I've also seen a number of people involved in significant work-related injuries, which may be vehicular or on work sites that have resulted in significant physical injuries. It might be multi-trauma or an acquired brain injury, but also people who may have been involved in work-related psychological difficulties or interactional difficulties that's called significant psychological distress, which has led to a psychiatric syndrome. I see regularly patients in a clinical perspective who have acquired brain injury, either through work-related accidents or vehicular accidents here in Victoria, and also see patients who have complex multi-trauma who often end up with significant physical disability, either through complex pain, traumatic, non-traumatic amputations, or difficulty with mobility because of complex orthopedic injuries. And these are all things that lead to significant psychiatric morbidity. I've had a role in seeing patients with mild traumatic brain injury, such as concussion, and I've played a role with sporting bodies, including medical associations associated with some of the major football codes in talking about the psychiatric sequelae of concussion, for example. In addition, because of my role at the Epworth Hospital in rehabilitation and brain injury, I will often see people who've made a significant self-harm attempt, often involving a vehicle, and so we'll have significant expertise in managing psychiatric illness and significant high lethality self-harm attempts that come through the private and compensable medical system. I think in a range of complex clinical situations, I can very, very quickly sort out the diagnosis, what needs to be done to stabilize someone's mental state, but also to think about what are the medium and longer term issues in being able to improve someone's capacity to reintegrate with the community, with work, and to improve their social and occupational functioning. I think it's very, very important that people engage with the process, that they feel heard, that they feel contained. And I think when you're able to really engage people, they'll take on board the treatment recommendations that you're able to glean from really taking a thorough and comprehensive history. I think that's something with a really broad range of expertise across so many different sectors, that I'm able to manage complex or even seemingly novel situations and fairly quickly find a treatment path that the patient will be able to come on board with. And through developing my relationship with the patient, being accessible, being engaged, being interested, being able to engage them in a treatment plan that fundamentally aims to restore their function and improve their function. I think for an injured person, when they go through a medico-legal assessment, they need to feel that they've truly been heard, that the breadth of their experience as a result of an injury is understood, is integrated with them as a person. And I think also in particular that an examiner doesn't have preconceived ideas, isn't closed off to their experience, so that they feel that they've truly been heard and that someone has been able to capture, understand and integrate the breadth of the effects of their injury on them as a whole person, as an individual, and what the downstream effects of that have been and their capacity to function in all the roles that they may have as a colleague, as a partner, a parent, etc., and a member of the community. I think I've got a lot to offer the medico-legal space in terms of having such a breadth of experience, having seen compensable patients for so many years as a clinician and treater, and really understanding their clinical journey. And I think also the capacity that a psychiatrist and a neuropsychiatrist in particular has at being able to integrate everything from development to the effects of physical ill health, potentially brain injury or cognitive disorder, with all other aspects of their daily functioning. I think a neuropsychiatrist is uniquely placed to do that. And particularly as I don't confine myself just to biological psychiatry. I've had a long-term interest in psychological therapy, have done for more than 20 years, and continue to see long-term psychotherapy patients in my practice, including people with childhood trauma, complex PTSD, for example. So I think the capacity to really bring together the psychological and the biological is something I can really offer clients and also referrers for me in an IME role.